An unstageable pressure injury involves full thickness tissue loss, a wound base covered by slough, yellow, tan, gray, green, or brown, and eschar in a wound bed that usually is tan, brown, or black. The true depth and stage of the injury cannot be determined until the base of the wound has been exposed. Stable eschar on the heels provide a natural biologic cover. Do not remove it. Suspected deep tissue pressure injuries. During this stage, the wound appears as a localized purple or maroon area of discolored intact skin or a blood-filled blister. This is caused by underlying soft tissue damage from pressure or shear. Characteristics of the area range from painful, firm, mushy, boggy, or warm to cool compared with adjacent tissue. In patients with dark skin tones, deep tissue injury is sometimes difficult to detect, but often start with a thin blister over a dark wound bed. The wound sometimes becomes covered with thin eschar. Even with prompt treatment, some wounds evolve rapidly, exposing additional layers of tissue. Interventions. Nursing interventions for patients with pressure injuries include ongoing assessment and evaluation of improvement. Assessment data include the size and the depth of the injury, the presence of any undermining, the amount and the color of any exudate, the presence of pain or odor, and the appearance of the exposed tissue. Healing is a long-term process. Therefore, be sure the plan of care is consistent over time and evaluated for effectiveness. Interventions are determined according to the stage of the injury. Boxes 9.5 and 9.6 and figures 9.5 through 9.7. Skincare. Although assessment for the pressure of skin impairment is a nursing responsibility and is not to be delegated, UIPs or CNAs provide hygienic care in many settings. Therefore, the CNA should be instructed in the following areas. Report any changes in the patient's skin conditions such as redness, irritation, dryness, maceration, or discomfort. Provide care to prevent the patient from exposure to body fluids such as urine, feces, wound drainage, and gastric secretions. Observe bony prominences, sacrum, scapulae, ears, elbows, heels, inner and outer malleoli, inner and outer knees, back of head, ischial tuberosities, trochanteric areas of the hips and heels for any signs of redness, irritation, or skin breakdown. Observe and prevent any areas of pressure from external devices such as oxygen tubing, nasogastric tubing, casts, braces, urinary catheter tubing, or drainage tubing. Provide perineal care as needed and observe the area for any signs of skin breakdown. Apply protective barrier creams as followed by facility policy. I think I am. Okay, I'm going to go over the guidelines, those boxes 9.5 and 9.6. Okay, so general guidelines for care of pressure injuries include never massaging reddened areas because it's a risk for further breakdown. Massage over bony prominences is no longer recommended. Massage results in decreased blood flow and tissue damage in some patients. Nutritional support, which promotes healthy tissue repair, is likely to be as important as local wound care for the patient. Observe the patient's hydration. If it is inadequate or if signs of dehydration, decreased skin turgor, and recessed eyes are present, carefully observe the patient's intake and output and monitor fluid replacement therapy as ordered. Turn patients who are on complete bed rest or unable to reposition themselves every 2 hours. It is important to avoid the full lateral position, which results in direct pressure on the trochanteric region. The 30-degree lateral incline position is preferable. Reposition chair-bound patients every hour. If chair-bound patients are able to shift their weight, teach them to do so every 15 minutes. Place patients who are at risk for skin impairment on a pressure-relieving mattress or chair cushion. Donut types of cushions are not advisable because they sometimes cause a congestion of blood to the area, resulting in edema and decreased blood flow to the area. Placement of a rolled bath blanket under the distal extremity helps prevent pressure injuries on the heels by floating. The term is floating. The heels. It raises the heel off the bed. Other pressure-relieving devices to try are therapeutic beds and mattresses. Examples of pressure-relieving beds are low air loss beds and oscillating support surface beds. In addition, there are the alternating air mattress and the water mattress. Many kinds of topical agents to facilitate healing are available to apply to the wound and edges of the wound. Take care to evaluate the effectiveness of any product used on the injury. Use with caution any products that have the capacity to damage fragile skin and prevent epithelialization, formation of new cells, such as hydrogen peroxide or alcohol.
Moving dependent patient to 30-degree lateral side lying position. This move removes pressure from the bony prominences of the entire back, but especially the greater trochanters. If patient is able to move freely, a side lying position with upper and lower shoulders aligned is acceptable. Procedure and rationale. Lower the head of the bed as much as the patient can tolerate, keeping head of pillow below 30-degree angle. Lower side rails. This reduces shear, prevents working against gravity. Using a pull sheet, move the patient to the side of the bed opposite. Using a pull sheet, move patient to the side of the bed opposite the one toward which the patient will be turned. Raise side rail. Go to the opposite side of the bed and lower side rail. Ensures that patient is in center of the bed when turned. Assist patient to raise arm nearest you above head, adjusting pillow if needed. Grasp patient's shoulder and hip and assist patient to roll towards you onto the side. Turning patient towards you promotes patient's sense of security. Flex both of the patient's knees after the turn and support upper leg from knee to foot with a pillow or folded blanket. Keep spine in good alignment. Ease lower shoulder forward and bring upper shoulder back slightly. Assess patient's comfort. Prevents excessive pressure directly on shoulder. Support upper arm with pillows so that arm is level with shoulder. This improves respiratory effort by reducing pressure on the chest to a minimum. Optional, you can place a pillow behind and under the patient's back so that it is snug smoothly against their back. Make certain patient's back is straight without evidence of twisting. Adjust as needed for comfort. Pressure points to assess include the ear, the shoulder, the anterior iliac spine, the trochanter, the lateral side of the knee, the malleolus, and the foot.